Psychotherapy process. The psychotherapy process is a 7-step process. The first step in the process is case history. This is the step on which we will discuss in this session. The psychotherapy process of 7 steps has step 1 is case history, step 2 psychological testing, step 3 diagnosis, step 4 pathogenesis, step 5 treatment plan or therapy, step 6 is supervision, step 7 is termination. This is one way to look at the psychotherapy process. Today we'll focus on the first aspect of the first step of the 7-step psychotherapy process, the step of case history. How to take case history? What is case history? What are the different types and formats in which a case history can be taken? So let us discuss on case history in this session. Case history, is it necessary? Before that, we go into what is a case history. Case history is history of a case, meaning if a person has come with a problem, say depression, we want to know the entire life story of the person and the history of how the sickness started and how it has developed over a period of time. This is the information we want in case history. History of a person, which includes the history of his life story, his entire life story, and the history of the sickness. So history of a case is case history, and by history of a case we mean life story of the person and life story of the, or rather the history of the sickness, how it has come into existence and how it has developed. So this is what we call is the case history. Second question is it necessary to take a case history? Case history is the first step of the psychotherapy process, and this is true for 99% of therapies. Some therapists don't go by this stepwise process and they go directly start with the therapy. And to 99% of therapists, this question even doesn't look like a credible question that should one take case history. They take it for granted that of course we should take case history. There is no way we can start doing therapy without taking the case history and understanding the patient and his problem. So the very question is absurd for most therapists. However, for some therapists, this is a very valid question and they go into details of this question. Should we take case history or should we directly go for therapy? Let us take a look at who are this 1% of therapists, or some will say not 1% but 5% or 10%, whatever be the exact number, but an extreme minority, a microscopic minority. Who are these therapists, which school they belong to, and why do they feel it is not necessary to take case history to start with? One can directly go into therapy. Let us understand their point of view. Some therapists in ISTDP don't take case history, they directly start with therapy. Some therapists practicing classical psychoanalysis also don't take case history, they just ask the person to get on the couch and start speaking about himself, and from this they deduce or they write out or they compile the case history. I should say they compile the case history. Deduction is not the right word. They compile the case history. Some therapists who practice existential psychotherapy, they don't go into much of case history because they are not so much interested in pathogenesis. as much they are interested in philosophical and experiential exploration of the person's life. Some Jungian analysts also don't go for case history. They request the person to start on the couch or face to face, as the case may be, and then mostly it is face to face, and then go ahead as the narration flows. So these are some of the areas where therapists don't take case history but directly go to therapy. However, a predominant majority, let me use 95% as a figure, they do take case history. They follow the 7-step process. 95% of therapists at least follow the 7-step process. They take the case history, if necessary go for psychological testing, arrive at a diagnosis, arrive at a pathogenesis, create a treatment plan, and only after understanding this whole thing go into therapy, because they want to go into therapy well prepared, provisionally knowing what they are dealing with and what is going to come up. On the other side are 95% of people who definitely take a case history, and their arguments are, why not use easily available data when it is available? Second, it is too risky to go into therapy directly without taking the case history. What if the person is psychotic, impulsive, violent, psychopathic, or extremely fragile? Unknowingly we can harm the patient, unknowingly we can render the psychotherapy process non-optimal, when it could have easily been optimal had we had the patience and the perseverance to take the case history, do the testing, do diagnosis, pathogenesis, prepare ourselves, prepare a treatment plan, prepare ourselves, and then go for therapy. So first, what is the wisdom in not using data available? What is the wisdom in not using psychological tests which are available? Why should we not use the tools and the knowledge we already have? How can we justify that we don't use the knowledge and the tools we already have? So from their point of view, it seems like something impulsive, something narcissistic, something that wants to avoid the hard work, something that the therapist wants a freedom of impulse, or the therapist is thinking of himself as omnipotent. So this is their first argument of why not use easily available data. How can we justify not using the existing knowledge and tools? Second, pathogenesis prepares us in terms of 100 things that come in therapy. What is the stance we take? Is it supportive, or is it interpretative? Is it challenging, or is it confrontational? What should we focus on? Are we looking primarily at a Freudian problem or a Kleinian problem? Are we looking at a person who needs interpretation or holding? What do psychological tests tell us? If we have prescribed any projective test, we already have some insight into the unconscious of the person. What do the tests tell us? What does any dream analysis tell us? We should not be re-traumatizing the patient without the case history. If we enter into a therapy, there is a possibility, especially for young therapists, to be extremely aggressive on a fragile person and re-traumatize the person. And often this can result in the loss of the patient, and this loss of the patient in mature societies, from a psychotherapy standpoint, it would just be loss of the patient to the therapist. But in countries like India or much of Africa, which are not psychotherapy mature, so to say, the patient does not have the knowledge that there are different kinds of therapies. So once he is dissatisfied with the therapist, he not only goes out of therapy for that therapist, but he does not access psychotherapy at all. And this is quite a common occurrence. So that it's not only loss of the patient to the therapist, but it is the loss of the patient to therapy per se, and it is the loss of therapy, the whole world of therapy to the patient. So we have to be extremely careful, especially in countries which are not psychotherapy mature, where illiteracy is high, poverty is high, that we don't lose the patient because of not having accessed the case history when we could have. And we should not cause damage to the patient who then doesn't seek psychotherapy ever again. Let us take a look at arguments from the other side also, why they justify not taking a case history. They say case history taking and doing pathogenesis brings in too much of theory. Rather, it is more practical and more on the ground to go as it comes. Instead of theorizing, let us be experiential and authentic and only deal with what the patient tells us and not make assumptions based on our theory. Second argument, they say theories are too weak. We are nowhere near a level where we can be certain about anything that the theory tells us. And theories are too many and too different, and we don't have the capacity to really synthesize and integrate a theory or create a meta theory which will include all theories. This being the situation, the predictions that theory makes are very weak. Third, it is too ambitious if somebody says, I will synthesize all the theories. Fourth, this too much of theorizing actually backfires for most therapists, and they don't listen to what the patient says because in the back of their minds they are listening to what the theory is saying. So these are arguments for not taking a case history. However, as I said, 95% of people do follow the 7-step process. Only 5% believe in these arguments, and these 5% I mentioned, they belong to ISTDP, classical psychoanalysis, existential psychotherapy, and some in the Jungian therapy. So these are the 4 who are 1, 2, 3, 4. They constitute the 5% who do not necessarily follow the 7-step process and don't take case history before they directly go into therapy. So they constitute the 5%, and these are the arguments of 95% who take case histories, and these are the arguments of 5% who don't take case history. Now, taking a case history might be a legal necessity in some countries. In that case, you don't have any option but to take a case history, regardless of what your personal beliefs are. In some countries, they even prescribe a format for taking a case history, and that can be for everybody. So you may have a separate format for psychiatrists, separate for therapists, or one format for both. But there may be countries where there are legal formats to take the case history. In some cases, there is a standard format for psychiatry. And in some situations, the professional societies have their own format. For example, International Psychoanalytic Society might have its own format of taking a case history. The Jungians, who have their own society, International Analytic Associate, I don't recollect the name, but the Jungian Global Society, it goes by some name, International Analytic Society or something. They have their own separate format of taking a case history. So professional societies of each of the psychoanalytic schools, they may have their own formats of taking a case history. Psychiatry as a profession definitely has their own format of taking a case history. And what therapists do in countries like India is they use this format of the case history format of psychiatry, which psychiatrists are using, and add to it whatever they want to add for their own psychotherapy, psychoanalysis purposes. They don't reduce anything, they add to it so that they are not found on the wrong side of law. Some people say, is it even a question that you should take a case history? It's obvious. But we should not forget what Heidegger said. Something can be too near to be found. So it may be that there is some substance, we may not agree with it, but there is some point the other group also has who does not take case history but directly goes into therapy. I personally always take a case history. I follow the 7-step process very religiously. I believe it is the best thing to do. But if somebody has the personality and the skills where they don't want to lose the heat of the moment when the person comes to you to give the case history, and instead of allowing that heat to dissipate in the process of case history taking, if you want to harvest that heat to heal the patient, and if somebody can pull it off, it's a wonderful thing to do. But I don't have the skills, so I prefer to follow the classical 7-step process. Now let us look into the case history. What are the contents of a case history and what can be added to it? So these 5 how do you select? These 5, they are 5 mandatory parts of any case history. As a standard, some schools, the Jungian school may have a separate format. International Psychoanalytic Association, IPS, International Psychoanalytic Society, can have a separate format. But if we say 95% of therapists take case history, then 75% of this 95% follow this format. That the case history must have personal information as the first part, complaints, second part, response of complaints to various treatment given to the patient, third part, life story of the patient, fourth part, and mental status examination, fifth part. The way you take the life story differs from psychoanalytic school to another psychoanalytic school. But these 5 parts are inseparable parts of case history. They constitute the structure of any case history, and this is true for 75% of people who take case history. In some cases, in other 25%, they may not go for mental status examination, which they believe is strictly of use to psychiatrists, not to psychoanalysts. Now, the case history is like the raw material which we put into a machine. The machine is the theory of the school we are following. And the output of that machine is pathogenesis. And from pathogenesis, we create a treatment plan. So if we look at any school of psychoanalysis as a machine, the raw material into the machine is the case history and the psychological test reports. And the output of that machine is pathogenesis. And from pathogenesis arises treatment plan. So this is one way to look at utility of the case history. And obviously each school is a different kind of a machine. And therefore each school requires case history in slightly different formats. The type of information that a Freudian needs is different from the type of information that a Jungian needs, is different from type of information a Kleinian needs, is different from type of information a Cohusian needs. So the Cohusian machine is different from a Kleinian machine, is different from a Freudian machine, is different from a Jungian machine. So each machine, each school requires case history in slightly different format. So those customizations are there. But in every case, the case history and the psychological test reports are inputs into the machine, which is the theory of the school, and output is pathogenesis. From pathogenesis, we create a treatment plan and then we start the therapy. Mostly what people do is they use a standard format for case history, which is a format of psychiatrists, and then add to it, go in a plus model. So they have these 5 elements, and if they feel like, they add in each of these elements. And mostly the addition is only in case of life story. The way we take life story, that is the point where most additions take place. What are the different types of case histories? Each school has its own format of taking a case history, in the sense that if you go here, the personal information part is same for all the schools. Complaints is the same for all the schools. Response of complaints is also same by and large. Mental status examination, some may keep it, some may not do at all, but the difference is in how do you take the life story. What questions you ask, what sort of information you seek from the person. That is where the difference is in each of the schools. So the Freudian school has its own format, Kleinian its own, Jungian, Cohesian, each of them has its own format of taking a case history. And as I said, the difference is largely in how you record the life story. Other parts are by and large the same. Some schools which are affect focused, like emotion centered therapy, or some other schools, they will take a case history based upon with a focus on affect. Some cognitive schools will take case history based upon thought. So they will ask more questions related to thought. They will ask more questions related to affect. Behavioral schools will focus more on behavior and will ask more questions and record more information based on behavior. Existential school will go more into the psychophilosophical aspect, almost a spiritual aspect of the person, experience of life, reflection of life person, and they will take the conversation into that color and flavor. So different types of case histories will emerge based upon which school of psychotherapy you follow. It would be a very good exercise if you can to see case history developed for the same person by different schools. Now let us come to the first part of the case history, personal information. So the case history, as we said, has 5 parts: personal information, complaints, response of complaints to different treatments over time, life story, and mental status examination. These are 5 parts of a classical conventional case history. Let us take a look at the first part, personal information. In personal information, we asked about these 10 parts, 10 points to the person. You can add to it, but this 10 you should include: age, gender, education, language, occupation, religion, family, who gave the reference, accompanying person if any, and if the accompanying person is ready to become an informant and give us information about the patient. We can request the patient to be outside for some time till we talk to the accompanying person or informant. And emergency contact. Whom should we contact in case of an emergency? So you can add to it. So this is the first part of case history, the part of personal information. And this gives us the first orientation towards the person. Second part of the case history is complaints. And the complaints part we divide into 5 points. First, if the patient comes with 5 complaints, maybe 1 or 2 of them are chief complaints and other are minor complaints. So we divide all complaints into 2 categories. We call it the chief complaints and other complaints or only complaints. Some people use the words chief complaint and general complaints. You can use any word you wish, but 1 or 2, the major complaints we designate as chief complaints, and other complaints we designate as general complaints or just complaints. General complaints is a better word. Then we ask the person about precipitating events which have precipitated the chief complaint and general complaints. So we take up complaint by complaint, and for every complaint we ask these three things. We start first with the chief complaint, or if there are two chief complaints, then one by one, and then we come to general complaints. But for each complaint, let us say there are two chief complaints and three general complaints, so 5 complaints in all. For each of the 5 complaints, one by one, starting first with the chief complaint number 1, then chief complaint number 2, then general complaint number 3, general complaint number 4, general complaint number 5. For each of them in order, we ask for precipitating events that activated that complaint. If the person has taken treatment over a period of time for that complaint, how has that complaint responded positively or negatively to each of the interventions? And what has worked and what has not worked for the person, either in terms of treatment or in terms of lifestyle or anything else he has in mind. These 5 parts help us in writing the second part of the case history, which is related to the complaints. So all the complaints we divide into 2, chief complaints and other complaints or general complaints. And for each complaint we ask, what is the precipitating event? We ask for history of the complaint and history of the treatment. When did it start and how has it responded to each of the treatments given, and what has worked and not worked, including the treatment, lifestyle, and any other thing the person has in mind. So this gives us a clear idea about the problems, the complaints, how did each of them start, how they have developed over a period of time, to what have they responded positively, to what have they responded negatively, what has worked and not worked for the patient. Third part of the case history is life story, and we cover the whole life story of the person in these parts. First, we talk about birth. Was the delivery normal or was it cesarean? Was it free of any complications or were there any complications? How was the infancy? Was the feeding normal? Was the crying normal? How was the attachment behavior with mother and father? Were there any sicknesses in infancy, especially sicknesses which would repeat itself? So in birth, if we take as 0 years, infancy you can take as 0 to 3 years, childhood 3 to 12 years, teenage 12 to 18, young age 18 to 25. Some people can go 18 to 35, middle age 35 to 55, or 35 to 60, and then old age. So we cover the entire life story in these areas. So in each of these areas we ask questions. For infancy we ask questions on feeding, crying, attachment, behavior, sicknesses. You can ask questions on more areas. I have listed just a few limited areas. The more questions you ask, the better information you get, and the better case history comes into existence. In childhood, we asked about attachment behavior, and that gives us an idea about if it was normal or impaired. If impaired, it was anxious, avoidant, the fears people have in childhood, the cruelty to animals, particularly small insects, and habits, if there are any non-normal habits, non-common habits appropriate to the age. In teenage area, we ask about friends, sexual orientation, heterosexual, bisexual, homosexual, dreams, if some dreams are repeating themselves, if some dreams are so pleasant that the person spends most of their time in dreaming, and sports, how was their behavior with friends and playing sports. In young age, we asked about relationships, career orientation, what he thinks, what he thought, what he did for a career in terms of education, and how was he with friends. Did he have adequate number of friends, few friends, no friends, or maybe just 1 or 2 friends? It's very important. Middle age, how has his experience of job been? What is the family experience like, and how does he experience life now, especially if the person is in a midlife crisis. In old age, we ask how he reflects on life, on his health, finance, his family situation, and anxiety towards an impending death. These are some of the points on which we ask information. In addition to it, these are some of the basic points on which we definitely ask for information. In addition to it, each school of psychoanalysis has its own list of questions to be asked in each of these phases. So this is a generic information that every school will ask, but in addition to this, in each of the phases, every school will have its own questions to ask, because they are interested in some phenomena in each of these phases which they believe is important for pathogenesis and healing. In most schools in psychoanalysis, the whole focus is from birth, infancy, and childhood. 0 to 5 years is the focus of most schools in psychoanalysis. Very few, like Erickson's, would go into post 5 years of age. Erickson would go, Jung would go. Apart from these two, most people will focus on 0 to 5 years. After life story, we come to mental status examination. And this is an area which an expert is supposed to fill up. This is an expert's page. Before mental status examination, we are asking questions what we want, but the information is coming from the client in his language, a layman's language, and we are noting it down exactly as he says it. So the noting down happens in a layman's language, in the client's language. But in mental status examination, this is an expert's page, a therapist's page, or a psychiatrist's page. And here the language used is by the expert. And this is not something that you ask the client, you could write it down yourself, because this is the end of the case history. This is the last part of the case history. So in the light of all that you know about the client and the way the client has behaved in front of you, right at that moment, on the basis of these two elements, the information given and the behavior of the person in front of you, in light of these two, you write down on your own, without asking the client anything, in your expert's language, the mental status examination, this last page of case history. It is filled on the basis of the interview as it was. So a person who is complaining of depression may be smiling with you. So you write down he smiles during the interview, although you know he's depressed. So we fill it up, MSc part, not pathogenesis. MSc part we fill it up on as is basis, as it was basis, as it was in the interview. MSc gives, mental status examination gives indicative information on the problems. Detailed noting down in the MSc saves you from remembering all the technical terms. So one way you can create the MSc form is to make it more detailed by writing down all the options. So if you have delusion, write down all options of delusion. So you only have to tick and you don't have to remember what are the various types of delusions. So the more detailed you make mental status examination page, easier it is to use it. Last part is remarks, where if you look at the entire MSc, it is by and large tick the box kind of format. So the qualitative information or details of what you tick mark or the context of what you tick mark, that is given as qualitative information in the end in the element of remarks. So there is a last point called remarks and open space where you can write down all the qualitative information related to whatever you ticked above. So these are the parts of This is how the mental status examination looks like. It has two parts. Part 1 has these elements and part 2 has these elements. And for every element, we use these words normal or impaired. If it is normal, nothing to worry. If it is impaired, meaning not normal, some sort of damage, some sort of difficulty, then we give details of what is not normal, what is impaired. So this is the normal status. So first element in mental status examination is consciousness. Was the person aware in front of you, or was he drowsy? Was he feeling sleepy? If he is normal, you say normal, the story ends here. If he is not normal, then you tick mark here and then give details that the person was drowsy. Maybe because he was not feeling well for some time, or he has taken some medication, the side effect of which is drowsiness. Whatever it is, details we mention. So we say impaired owing to ABC. If it is normal, you don't have to say anything more. But if you say impaired, not normal, then you have to detail it out. What is it not normal? Why is it not normal? Second is attitude. So first relates to being aware, alert, or being drowsy, sleepy. Second element is attitude. Attitude refers to, is it cooperative or not cooperative? So we say cooperative. If yes, we tick it. Not cooperative, we tick it. If we say not cooperative, then we detail it out. Why not cooperative? Like when you ask a question, is he ready to engage with you, or does he hesitate in giving information and sitting for the interview? If he has not come of his own volition, but if he is come pressurized by family members or pressurized by the superiors at job, then attitude usually is non-cooperative. Dressing and grooming. Does he have is the self-care function intact, or has the self-care function got damaged? If it is damaged, dressing and grooming will not be appropriate to the occasion. If it is normal, we just say, and this is very contextual and cultural. Like in India, dressing is not looked upon as intently in case of male members of society like it is in USA or some European countries. So dressing and grooming will be far more important a variable in those countries rather than India, where people take it very casually. Eye contact. Was the eye contact maintained, or was it difficult for the person to maintain eye contact? So was it not eye contact, not, we say maintained or not maintained? If not maintained, then we go into reasons if we can. Psychomotor activity. Was it normal or not normal? If not normal, then there are various types, various categories in which we can classify not normal. Was the person fidgeting? Was the person shaking legs? Did the person want to get up, walk a bit and come back? Was the body shaking? Was there pain in some part of the body? So these are details of psychomotor non-normal activity. If it is normal, we don't have to say anything. But if it is non-normal, then what is the type of non-normal? That there is a whole list of non-normal possibilities in which we have to take whatever is relevant and explain what is there. Then we come to mood. If it is normal, we just say normal. If it is not normal, then it can either be on the high side or the low side. On the high side, how high? On the low side, how low? So there is a full continuum on the higher side and a continuum on the lower side, and we have different names. Like if it is on the higher side, we say elevated mood. Even higher than that, euphoric mood. Even higher than that, ecstatic mood. Similarly, on the lower side, dysphoric mood, melancholic mood, or major depression. So different books will give you different kinds of classifications, but we can say if it is not normal, that on the higher side, there are categories based upon intensity. On the lower side, there are categories or names used based upon intensity. We take it. If you put it all printed in the MSc form, you don't have to remember the names of those categories. Speech, normal or not normal? If not normal, what are the non-normal elements? It can be circumambulation, like somebody going in circles. It can be tangential, somebody talking tangentially. It can be not relevant and coherent. It may be repetition of certain words, echolalia. So there is a whole list of what non-normal speech is, and based upon it we have to take. Second part, higher functions. First is sensorium, is the sense. If all senses working clearly, the sight of seeing, the sense of seeing, the sense of hearing, the sense of touch, is the sensorium clear? If yes, we say normal. If not normal, then we mention what is not normal. Attention and concentration, is it there? If normal, story ends there. If not normal, we mention the details. Memory, normal or non-normal. Impulse control, normal or impaired. If impaired, details of it. Intelligence, normal or impaired. If impaired, then details of it. And this is something where if we say impaired, we have to do an IQ test. And judgment, is the judgment proper or is the judgment if the person is not capable of taking a prudent judgment. Insight, is the insight there or is the insight missing? Usually the insight would be there except in psychotic cases or cases of mental retardation. And if there is insight, what is the level of insight? Is it just insight that the problem exists? Is it intellectual insight about the details of the problem, or is there emotional insight of why the problem emotionally would be there? So you can see for each of these elements, awareness, attitude, each of these you can have a psychological test. For each of these elements you can have a test, how to measure each of them. But obviously nobody can do all the tests unless something is imperative. So normally what we do is we say, when we say intelligence is normal, we say normal, clinically normal but not tested. We say clinically normal but not tested because we have not done a psychological test. So we qualify our saying normal by saying clinically normal but not tested. So it appears normal to us based upon the interview, that is a clinical normal, but we are not tested. So we say not tested but clinically normal. So these are the elements of mental status examination, the last part of the case history form. So these are the 5 parts of any case history, and normally to take down case history we can use a notebook or we can use a printout with blank lines where we can fill in the information, which is called the case history form. So case history form is nothing but a printout that we use to record case history. And it's always a good idea to have 10 to 15 photocopies of a case history form ready. So whenever need be, we can use it. And the case history form has these 5 elements. First element is personal information. Second, part 1 is personal information. Part 2, complaints. Part 3, response to complaints. Part 4, life story. Part 5, mental status examination. So these are the 5 parts of any case history, and we should always have 10-15 photocopies of a case history form to record the case history ready with us. So with this session discussion is over. Now what I will do is I will share with you a real life case history form where it is based upon, I have taken the case history form of psychiatrists as they use it in India and added to it so that we can get more information necessary for psychoanalysis. So it's a psychiatry plus format, and that I will share with you. So you can have a look at in real life how case history form is like and how do you note down the information. Thank you for being with me. Let me just share the case history form. Case history form, a real life case history form based upon a psychiatry plus model. I have taken the case history form used by psychiatrists in India and added to it from to get information necessary from psychoanalytic standpoint. So this is the first part of the case history. The first page is the personal information related of the client. So first part of the case history form is personal information, name, age, gender, and so on. We take the signature of the patient and signature of the caretaker or guardian. Second part relates to the complaints. Second part of the case history, as we saw, is complaint. So we note down the chief complaint and we note down the history of the chief complaint, how did it appear in the first place and how it has developed and what are the precipitating events which cause the complaint to become active. Then we go to general complaints, other complaints, and do the same of taking precipitating events, physical and psychological symptoms, as well as how it developed. Then we go into past medical and psychiatric history. So this till here it completes our second part of complaint. Second part of case history is complaint. So here we say chief complaint, history of the complaint, how it has developed over a period of time, to what it has responded well, to what it has not responded well. So here the second part ends, and the third part, the life story begins. The life story begins with birth, infancy. You can call it infancy or early history. Psychiatrists use the word early history. In that, we look at crying, feeding habits, separation anxiety, transitional objects, toilet training, attachment behavior, recurrent fantasies as a child, and we have to ask some questions to see if a cohesive ego was developed slowly over a period of time in the first 3 years, particularly towards the second and the third year. Do we see ego cohesion in the 2 to 3 years of gap, or even in that period we see too many disintegrations of the ego? How to ask questions on this is a separate part, because that requires some grounding in the cohesion theory. Then we come to the middle childhood, in which we ask questions on gender orientation, identification, punishment, friendships, group standing, antisocial behavior, general aggression, cruelty to animals, and so on. Questions on masturbation, transitional objects. Then we come to late childhood or adolescence, 11 to 18. We ask about social group values, relation with teachers, hobbies, sports. Then we come to adulthood. We ask about self-esteem, occupational history. If military service is compulsory in your country, then military history. Social relationships, sexual activity, relationship history. Attitude to opposite sex, if the person has been married, homosexuality, educational history. We also ask about psychosexual history, sexual knowledge, sexual activity, orientation, masturbation, and here we ask particularly about what Freud calls central masturbatory fantasy. So we ask about what are the masturbatory fantasies usually, and are there some fantasies you reuse again and again, and then we try to deduce what is at the center. Is there something common in the recurrently used masturbation fantasy? And that Freud says is very important, and it's indeed so, the central masturbatory fantasy. Very important part is who is left out. Towards the end of the life story, if we ask, is the father left out, is the brother left out, are the friends left out, are the teachers left out, who is unconsciously left out is very important. And once we recognize that, we probe in details. After this, with this, the life story gets over, and then last part is mental status examination. This is the last part of the case history form. So as we talk, this consciousness normal or impaired, we just tick. If we tick normal, the story ends there. If we say impaired, then we note down in the remarks what it is, or we can write down here itself by providing some blank lines. What is the impairment about? Attitude, cooperative, partially cooperative, non-cooperative, we tick. Dressing, group, normal, inappropriate. Eye contact, maintained or poorly maintained. Psychomotor activity can be normal or not normal. If not normal, then these are the options. Agitation, hyperactivity. They designate a continuum, the intensity and flavor of non-normal psychomotor activity. Similarly, mood. Is it normal or not normal? Normal, then we just tick here and it ends. If it is not normal, then we can go for any of the other choices. And essentially, they are designating intensity and flavor on the higher side and on the lower side. So elevated, expansive, euphoric, ecstasy, exaltation, these are on the higher side. Dysphoric, melancholic, depressed, these are on the lower side. Affect. Was he able to express full affect related to what he was saying, or was it restricted, even more restricted, blunt, or labile? Labile means it keeps changing on the face. Emotions keep changing on the face. Labile. Speech, was it normal or impaired? If impaired, then how was it impaired? So these are all impairments of speech. Whatever applies, you just tick it. Now, these words may not be familiar to you. For that, you will have to do some course in clinical psychiatry, or just go into the books, the basic book of Kaplan, and you will see what this means. Coprolalia, echolalia, dysarthria, aphasia. Thought, normal or impaired. If it is impaired, then these are the flavors of being impaired. Whatever applies, tick it. Delusion. Does the person have any delusion? Of course, it refers to psychosis. Delusion of broadcasting, somatic delusion, delusion of persecution, delusion of grandeur, whatever applies, tick. Hallucination. Here the word uses perception, but almost like hallucination. In perception, is the person normal or hallucinating? So perception, if normal, okay. If the perception is not normal, then of course it's hallucination. Then what is the nature of hallucination? So hallucination is here. So perception, we have normal, illusion, or hallucination. So if it is not normal, if it is impaired, then it can be either illusion or hallucination. If illusion, it's okay, we just note down the illusion. But if it's hallucination, then there are various types of hallucination. So we go into visual, auditory, tactile, and then within auditory, what are the kinds of hallucinations and so on. And lastly, we write down the remarks. So here we note down the contextual, the qualitative, the causal, the healing aspects related to anything that we have ticked above or noted above. We detail it out here in remarks. Then we come to higher functions. Sensorium, is it clear, blurred, hypnagogic, like just before the sleep? So attention and concentration, or this is after the sleep when you wake up. Attention normal and concentration normal or impaired. Memory normal or impaired. Impulse control, same. intelligence, judgment, whatever is there, we tick. And if it's a normal, nothing to worry. If we say impaired, we have to detail out the impairment. Insight, complete denial, slight awareness, aware but disowning of sickness, aware and accepting of sickness, intellectual insight on how the sickness operates, emotional insight on how the emotions are involved, true emotional insight which allows the person to bring about change. All those states of insight can be there. Insight can be at any of these stages. Whatever applies, just tick it there. If you want, you can write down the remarks and have blank lines here. Then you can note down the contextual, qualitative, detailed information about whatever you have ticked in the higher functions, just as you had in the first part. You can always, a good practice to have remarks and blank lines, so you can write down the qualitative, contextual aspect of the discussion. So this is one format of a case history form. Usually what happens is you start with somebody's case history form like this one, and then over a period of time, based on your experience and practice, you customize your and develop your own case history form. In the long run, each therapist develops his own case history form. So with this, we complete today's session on case history, which is a very important element of the psychotherapy process. Thank you for being with me. For any questions, write to me at hvindia@gmail.com.